no disclosure to this, since because I got some help from my friends in Al-Qasimi. It's one of the leading hospital in UAE, do actually most of the imaging, more than 90%, and they use all the devices. I think the two previous speakers emphasized about the calcification, which is, in our coronary is up to 20% nowadays. Actually, in our region, even more, because of the, all the risk factors that we're leading in the world, and we are aging population as well as renal problem. So really, when we come to the stent, without affecting our stent expansion, dissection, or the stent progress as they call it. So we have an expert here with us, Dr. Menz and others. They're talking about imaging, because that's what, at least what device to use when you come to debulking these calcifications. So I'm not here to tell you the difference, but IVIS is more available in our region than OCT, because there's more studies there. I know the color is nicer with the OCT, but again, we have renal problem patients, so we've and again need more experience with OCT, I think. The problem with angiography, it's everyone use angiography. That's why we based our final results as well. You can see in any live cases, they want to see the last angio. They want to see the IVIS most of the time, or OCT. So, but the problem with the angiography sometimes deceive you, doesn't give you the right answer. Where you think is maybe there is a calcification is too extensive, is not the case. Dr. Menz already mentioned these things. These are the criteria we use to decide about what debulking to use for OCT and IVIS. And of course, when to have one thing of these available, I think in my cath lab I use IVIS, but I'm talking about my colleagues here, Qasimi, they like OCT. In this case, when I present with you, it's just about how to use IVL, which again, I don't use that much. Again, it's from my colleague. And that's it's very use-friendly. You don't need much experience of it, so it's similar to a balloon, but a bit more bulky than others. But just a few cases, then you become familiar with it. But before that, you need to prepare the lesion, of course. So, this is an example of the cases when you do before and after to see what the disruption happens. Is a sonic disruption to the calcium, mainly from superficial to the deep. Although some of our experts here don't believe there's a deep calcification affect the outcome, and I, to some degree, agree with them. And this is the problem if you don't have these things, you will use with your non-compliant balloon or others might cause perforation. So it's very safe. And these are, again, mentioned by our expert here that, these are the studies we looked at the IVL, very safe, and hardly any perforation seen. And that's, that make life much easier. It gives you same results as, non-calcified arteries. And these are already mentioned. So this is a case I want to, from Al-Qasimi, which is, as I said, very, the lead, they do imaging in every case, and they have IVL usage, very high volume. So these are the patients we get in our region, very young. This is kind of, we call it old, because most of the calcification even happen in less than 40. So there's a 55 diabetic, very common diabetes in our region, hypertensive, came with acute coronary syndrome, another institution. They looked at his arteries, they found calcification. LAD is very long, diffuse, and RCA already occluded. So they said, better for you to go for bypass. Again, our region don't like major operation like that, so he went to this hospital. So RCA was done, stented, then remained the LAD. We can see diffuse, long, and different views, and this is again, this is the type of diabetic calcified arteries you get. So really, if you look at the Euroscore and other syntax and things, intermediate maybe, and can go for both actually. So the plan was here to do the OCT imaging, understand the location of the calcification and the burden of the calcification, so superficial, deep, thickness, arc, all that linked, and the length. Then to see if we can, do the imaging. If not, then rota, then tripsy, so rotatripsy, something like that. and then finish with OCT. So this case, we're not able to do the imaging. And then again, I don't think they tried to go with the balloon. They went with the rota here, and I think this is the algorithm. I think will be discussed later on by my other speaker. But this is the things we follow. If you cannot pass the balloon or imaging, then you go for rota, and this was another algorithm. So this is 1.25. I know some of you don't like 1.25, but again, they had to find something to at least penetrate that artery before we do the imaging. And 1.25, you know, is kind of broach that artery inside. But again, you know, looking at the, I'll quickly go through this. So still, you know, the lesion was not, you know, properly prepared for to put a stent. They found, you know, some nodules, some thickness there, and you can see. Just quickly go. I mean, you still have time. So these are the thickness and the arc of the calcification, mainly at the proximal and the mid. So they went with a bigger, of course, rota, you know, 1.5 here. So after that, they were happy. But again, the calcification, they found their nodule, as well as I showed you, still there. They wanted to, you know, debulk that. So they went with, I can show you now here. Let's change, of course, to the. So this was the 2.5 by 12. You go up to the 4, and then give your up to 10. Then do the proximal part as well with the bigger one. So they will use 2 balloons here, 2 shock waves. After that, they were happy. Then you do. After that, you go with the NC balloon for mid and proximal. Nicely dilated. I mean, what I do normally, I mean, this is maybe different than others. When I see this, I don't do imaging anymore. I mean, for myself, I really finish with, you know, maybe this is what I do. DCB, I do most of my cases nowadays. Stay away from a stent because of many reasons. Maybe next time I'll talk about that. But this case, of course, they put a stent in the mid and then proximal, use different sizes here, and then post-dilate that with the. Now, always sometimes you have problem with these stents, because, you know, you either lose one of the branches, or and here you can see some, you know, have the problem with the diagonal. So 3.5 by 23. So that was the final results of the. Not bad, but, you know, we can, you know, it's the flow you can see is still down, but you know, I think they were happy about that, and they looked, of course, the OCT after the stenting. You look at the expansion, knee dissection. You look at the knee. Overlap 2 stents. So this was the case, you know, where, you know, we need to use the both rota and tripsy. So rota tripsy, and I think, you know, IVL nowadays, if you want to stay safe away from, you know, no reflow and, you know, perforation, all that is nice to have it. So take-home message is calcified lesions are associated with the worst procedure outcome. Intracoronary imaging means really make your life much easier. You know what device to use. Choose of atherectomy, I think, is important when you come to not able to pass that lesion, especially with the balloon or the imaging. and shock wave is to if you want to debulk the superficial and the deep and sometimes the nodule, of course. So there is no device which one is best, but it depends on pre-procedure planning, technical expertise, of course, you need that, and device ability and patient lesion tailored approach. Thank you very much.